welcome back to the deep dive. If you are a medical student staring down the barrel of, biochemistry exams, or maybe just trying to make sense of those vast, terrifying tables of normal values in your textbooks, well, this deep dive is specifically for you.
Oh, we've all been there, staring at a page just full of analytes, abbreviations, units, and you just feel instantly overwhelmed. It looks like a dictionary of disease, but without any context, it's really just noise.
Exactly. That's why today we're going beyond just, rote memorization. We are building a conceptual map. We are cracking open section 35. Laboratory reference ranges from Davidson's medicine.
It's a critical resource.
Hmm.
And our mission today is to transform this really dense collection of numbers. I mean, it covers everything from blood to the CSF in the brain into a highly structured and hopefully memorable guide.
Right. The goal is not just to know that sodium is 135 to 145.
No, it's to understand why that range is so strictly governed, what the units actually signify, and crucially, how biological factors like age, sex, and ethnicity force the boundaries of normal to constantly shift.
We want to give you those mental anchors so that when you hit the wars, you don't panic when you see an abnormal result. You'll recognize the framework, you'll spot the exceptions, and you'll know exactly what questions to ask about the sample collection itself.
This is really your shortcut to being well-informed about the absolute foundation of patient diagnosis. So let's start at the very beginning with the foundational language the lab speaks, the International System of Units.
The SI units.
The first, and I think often underestimated, cornerstone of interpreting any lab result is understanding the International System of Units. SI units. I mean, if you trained in one country and then you move to another, SI units ensure that, say, 1 millimole per liter of glucose means the exact same thing everywhere.
I like to think of it as the Rosetta Stone of global medical communication. And history is important here, right? These units were formally agreed upon internationally way back in 1960.
Right, and before that standardization, different regions used wildly different measurements. It made cross-border research, even just patient transfers, dangerously complex.
So while some non-SI units still kind of stubbornly persist.
They do, especially in older systems, which is why you'll often see textbooks provide both. But SI units are the global standard. You, as a new clinician, you really have to operate primarily in the system.
Okay, so let's anchor this. We're talking about core SI units. The meter for length, the kilogram for mass, the joule for energy, those are all familiar. But in the chemical world of lab results, the real star is the mole.
The mole, yes. It defines the amount of a substance. It's a specific, huge number of particles, Avogadro's number. And this is essential because so many clinical processes, especially things like electrolyte balance, they depend on the number of particles dissolved in a solution, not just their mass.
And that gives us molar concentrations, like millimoles per liter and mole.
Exactly, which are the standard for sodium, potassium, glucose, all the big ones.
It's also worth noting the convenience unit for volume. The base SI unit is the cubic meter, which is huge, 1,000 liter.
Way too big for our purposes.
Right. So for routine lab work, the smaller, more manageable liter is the recognized unit we use every day for blood concentrations.
And since clinical chemistry deals with this enormous scale of quantities, from grams all the way down to femtomoles, we rely so heavily on those decimal multiples, the prefixes. You have to have those factors locked down, or you're just asking for conversion errors.
Think of it like jumping up or down 3 steps on a scale. Kilo is the big leap up, 10 to the power of 3.
And going smaller.
You've got milli, which is 10 to the minus 3, micro at minus 6, then nano, pico, and femto, going all the way down to 10 to the minus 15.
And let's be really practical about this. If you confuse milli and micro, you've just introduced a 1,000-fold error. A drug dosage in milligrams that you give in micrograms is 1,000th of the dose.
Which could mean total therapeutic failure.
Or you reverse that mistake and you're risking lethal toxicity. Mastering these little prefixes is absolutely essential for quick, accurate, and safe conversions.
Okay, so we have the rules.
Yeah.
But medicine is, of course, full of exceptions.
It is. Despite the push for standardization, there are historical conventions and just functional exceptions everywhere. We should probably cover the 3 big ones.
Let's do it. First up,
blood pressure. The SI unit for pressure is the Pascal, but by universal convention, blood pressure is always measured in millimeters of mercury, mmHg.
a throwback to the old mercury manometers.
Exactly. It's just what everyone uses.
Okay, exception number 2 relates to big molecules, particularly proteins. The mole is great for small things like sodium, but why do we switch away from it for proteins?
That's where molar concentration kind of breaks down. For proteins or other substances that don't have a really well-defined, uniform molecular composition, well, calculating the precise molecular weight you need for a molar concentration becomes difficult or just not relevant.
So for practicality, what do we do?
We just default back to mass concentrations,
Yeah.
so grams per liter or micrograms per liter. We're measuring the bulk presence, not the number of individual units.
And the third exception, and this is a huge source of confusion for students, is when we measure an effect instead of a mass.
Right. Enzymes and some hormones. When you measure, say, ALT, you aren't measuring how many grams of ALT are there. You're measuring its catalytic activity, how fast it's working.
So how fast it's turning a substrate into a product over time.
Precisely. And that's done via a bioassay, where you compare your patient's sample against a standardized sample. And because we're measuring activity, not mass, the results are given in these arbitrary units per liter or international units per liter.
And these can't be easily converted back to grams per liter.
Nope. They're measuring a completely different concept, functionality.
Oh. Okay, so we've got the language. Now for the ranges themselves, the source is very clear that the ranges they cite are just guidelines. They're not universal law.
Mm-hmm.
So why would sodium be 135 to 145 here, but maybe 134 to 146 in a hospital just 10 miles away?
That variance exists because ranges can vary significantly between labs, and it's often due to differences in the specific analytical method, the assay that they use. A different machine or a different chemical reagent might just slightly skew the results.
So you always need to check the local lab's reference range.
Always. Now, that said, maybe the single most critical distinction for any student to grasp is the non-interchangeability of serum and plasma. This is such a high-yield concept.
Because mixing them up causes a pre-analytical error. The test is run perfectly, but on the wrong sample, so the result is useless.
Completely useless. And it's a fundamental concept. Serum is the supernatant, the liquid left over after blood has been allowed to clot.
Whereas plasma is the liquid from blood that was collected with an anticoagulant, so no clotting happened.
Right, which means the clotting factors are still suspended in the plasma.
Okay, so give us the textbook examples where mixing these up leads to a total failure of diagnosis.
Let's lock down the two from the source. Critical example 1, fibrinogen. Since fibrinogen is a primary clotting factor, if you let the blood clot, the fibrinogen gets used up. It's gone.
So if you measure the serum, the level will be near zero.
Exactly. You must use plasma to accurately measure fibrinogen.
So if the test needs the clotting factor, you need plasma. Simple.
Simple. Now, critical example 2, paraprotein electrophoresis. Here, the reverse is true. You need serum.
Why?
Because if fibrinogen is present, like in a plasma sample, it migrates as this discrete, prominent band during electrophoresis. And that band directly interferes with the zone you're interested in, the gamma region, where those abnormal paraproteins show up.
So you have to get rid of the fibrinogen by letting the blood clot, which gives you serum and a clean read.
You've got it.
Okay, let's wrap this section up. The language is SI, but we accept conventions like MAHG and kinetic units like UL. And critically, collection detail, serum versus plasma, can make or break a test.
So, key takeaway 1, the language of medicine is SI, but be prepared for those conventions. And remember that collection details are critical, not interchangeable. Failing to pick the right tube is a common but totally preventable pre-analytical error.
This feels like a great place for a quick mental check-in.
Let's do it.
All right, here's the check-in question for you listening. If you need to measure the coagulation cascade's final product, fibrinogen, but you accidentally use a serum tube instead of a plasma tube, what clinical pathology might you mistakenly conclude the patient has?
If you miss that, you might falsely think the patient has a severe clotting disorder, severe hypofibrinogenemia, when really the sample just clotted in the tube. The fibrinogen is just absent from serum. So if that wasn't immediately clear, please just rewind and listen to that fibrinogen serum example again. It's that crucial.
All right, moving on to the bedrock of clinical diagnosis, venous blood chemistry. Starting with urea and electrolytes, the UNEs, this is the status report for fluid balance, kidney health, and electrical signaling.
Right, when you look at the major electrolytes, I think we should use the concept of the tightropes. These analytes exist within incredibly narrow ranges because they govern processes that just don't allow for deviation.
Sodium and chloride are the big ones for osmosis. Sodium is between 135 and 145 millimole L, chloride 95 to 107. And those tight ranges just reflect the body's obsession with controlling osmolality, the concentration of solutes in the blood.
Primarily regulated by the kidney and hormones like ADH. A deviation of just 5 millimoles in sodium can indicate severe hydration problems or complex hormonal issues.
And then there's potassium, K plus U, which is maybe the tightest rope of all. It's just 3.6 to 5.0 millimole.
And that's because potassium primarily controls cell membrane potential, especially in the heart. If it's too high or too low, you can get life-threatening cardiac arrhythmias.
And this is where we have to come back to that serum versus plasma issue.
Yeah.
This is hugely relevant for potassium. Why does the source specifically say that serum K plus values are, on average, 0.3 millimole higher than plasma values?
That zero point 0.3 difference is because of the clotting process itself. When blood clots to form serum, platelets and other cells rupture just a little bit, and they release their intracellular potassium into the fluid.
So that release slightly but consistently bumps up the serum potassium level compared to plasma where the cells stayed intact.
Exactly. This phenomenon is called pseudohyperkalemia. It's not real.
So if a patient's serum K plus is, say, 5.2 millimole, that's technically high. But if you subtract that 0.3 difference, their real plasma K plus might be 4.9, which is normal.
And that's the clinical dilemma the clinician has to ask. Is the patient truly hyperkalemic, which needs immediate treatment to prevent cardiac arrest, or is this just an artifact? You might need to redraw a plasma sample to confirm. That tiny difference dictates huge clinical action.
Okay, moving to renal function. Urea and creatinine.
Yeah.
Creatinine is a waste product from muscle metabolism, so its level is a direct function of muscle mass.
And that immediately introduces clear sex differences in the adult ranges. For males, it's 64 to 111 molzo, and for females, 50 to 98. This just reflects the average higher muscle mass in adult males.
Which has huge implications. When the lab calculates an estimated GFR, the eGFR, they use the patient's creatinine, age, and sex. If you get the sex wrong in the formula, the kidney function calculation will be inaccurate.
Potentially delaying a diagnosis or causing drug dosing errors, it's critical.
All right, let's look at the liver team. This group tells us if liver cells are damaged or if the liver's plumbing system is blocked.
Right, so the hepatocellular damage markers are ALT and AST. High levels usually mean the hepatocytes, the liver cells, are leaking their contents into the blood.
And in contrast, you have alkaline phosphatase, ALP, and GGT. These are often markers of cholestasis, a blockage in the bile ducts.
So ALP also comes from bone, which is important to remember. GGT is particularly useful. It can signal alcohol excess or certain drug effects, and like creatinine, it has a clear sex difference. It's 10 to 55 UL for males, but only 5 to 35 for females.
So a man with a GGT of 40 is normal. A woman with the same result is abnormal, and that would prompt an investigation.
Precisely. We also look at bilirubin, the yellow pigment from red cell breakdown, and synthesized proteins, especially albumin. Albumin has a long half-life, so a low level is a reliable, though nonspecific, sign of chronic liver failure or severe malnutrition.
And finally, for this group, metabolism markers. Fasting glucose for a snapshot in time, and HbA1c glycated hemoglobin, which gives you that 2 to 3 month average of glucose control.
Right.
Okay, this next part has what I think is the most shocking example of how a normal range is defined by patient demographics. Creatine kinase, or CK.
CK is released when muscle tissue is damaged, and this is why the source so critically emphasizes the ethnic variation. People of African and Caribbean origin typically have CK levels 1.5 to 2 times higher than people of European descent.
This is such a critical point. Why does this physiological difference exist?
The current thinking points towards a higher average muscle mass density and different resting membrane permeability in populations of West African descent. It's a purely biological difference, not a pathological one.
So if you have a patient of African descent with mild aches and a CK of 300 UL,
You have to factor in this physiological baseline. If you use the European reference range, you might start an unnecessary and stressful investigation for rhabdomyolysis. This understanding prevents overdiagnosis.
it's the essence of context. Okay, what about cardiovascular risk? We have CRP, C-reactive protein.
which is a general marker of systemic inflammation. We also use high-sensitivity CRP assays to estimate long-term cardiovascular risk, linking that low-grade chronic inflammation to atherosclerosis.
And lipid panels are complex. There's no single ideal cholesterol level.
Right. It's totally individualized based on the patient's risk factors. We look for negative indicators like low HDL cholesterol and assess triglycerides.
And troponins, the markers of a heart attack. Why does the source say interpretation is crucially dependent on the specific assay?
Because modern high-sensitivity troponin assays can detect incredibly tiny amounts of protein. The cutoff for defining a myocardial infarction is the 99th percentile of a healthy population.
And because every lab's method is slightly different.
That 99th percentile value, the line between normal and MI, is specific to that lab. You have to interpret the result in the context of the clinical picture and the specific cutoff provided by that lab. A result of 20 might be normal on one machine, but diagnostic of injury on another.
Got it. And briefly on toxins, carboxyhemoglobin, it's often high in heavy smokers.
Yes, the reference range actually allows for up to 8% in heavy smokers. That's their baseline. Anything significantly above that, you think about carbon monoxide poisoning.
And ethanol levels give a pretty sobering scale of impairment. Marked intoxication around 65 to 87 millimole, stupor, then coma above 109.
Yes, those numbers translate directly to critical loss of neurological function.
Okay, let's consolidate this section.
Key takeaway 2. When you're interpreting enzymes like CK or GGT, remember that sex and ethnicity are biological factors that define normal. Never treat the ranges as universal. And for electrolytes like potassium, pay attention to collection methods to avoid treating pseudo-hyperkalemia.
Time for another check-in. This one tests your clinical judgment against the numbers.
All right.
Check-in question. A middle-aged man who is a heavy smoker presents to the emergency room with mild flu symptoms. His carboxyhemoglobin is 5%. Should this immediately prompt carbon monoxide antidote treatment?
Well, if you remember that the reference range for a heavy smoker allows up to 8%, a level of 5% is likely normal for him. So no, it shouldn't immediately trigger an antidote. The context of his smoking history normalizes that finding.
Right. It highlights the importance of patient history over isolated numbers. Okay, we now shift from the static chemical environment to the dynamic world of hormones, the context-dependent messengers. This is one of the trickiest areas.
It really is. We need an anchor here, and I think it should be the hormonal calendar. A random hormone reading is almost meaningless. You have to layer on context. Gender, age, time of day, pubertal status, menstrual cycle stage, even patient posture.
So let's elaborate on that context. How does simply standing up change your lab results?
The renin-angiotensin-aldosterone system, the RAAS, is highly sensitive to posture. When you go from lying down to standing up, the change in pressure activates the RAAS to maintain your blood pressure. This means aldosterone and renin concentrations shoot up.
So an aldosterone of 700 penal is high if the patient was lying down.
But it's well within the normal limits if they were standing. That one detail posture is completely determinative.
And what about time of day?
The circadian rhythm controls the adrenal axis. Cortisol and ACTH peak in the morning. So for ACTH, the normal range is for a morning sample, 1.5 to 13.9 pMol. A level of 10 at 8 a.m. is normal, but that same level at 8 p.m. would suggest a loss of normal rhythm, maybe pointing to Cushing's.
The source also mentions that cortisol and growth hormone often need dynamic testing. What does that mean in practice?
It means a single random level tells you very little. To diagnose an issue, we have to test the system's capacity. So for cortisol, we might do a synecthin test, an ACTH stimulation test, to see if the adrenal gland can respond properly. Dynamic testing, looking at the response over time, is often way more informative.
Right. And shifting to reproductive hormones, progesterone is the classic example of cycle dependence.
Yes. Progesterone confirms ovulation. The level has to be greater than 30 onmol in the mid-luteal phase, about 7 days after ovulation, to show the cycle was ovulatory. The exact day of the menstrual cycle is non-negotiable context.
Finally, vitamin D, where biology meets environment. The definitions are pretty clear. Normal is over 50 onmol, insufficiency is 25 to 50, and deficiency is under 25.
But the environmental context is key. Levels vary with the seasons. They're higher in summer because of UV exposure. So a level of 45 might be insufficient in July, but in the middle of winter, that might be the highest that patient can naturally achieve.
Okay, let's switch gears completely. From the slow calendar of hormones to the rapid crisis assessment of arterial blood gases, or ABGs. This is the fast check.
The fast check, I like that. ABGs are essential because our bodies demand a tiny pH window to function. That window is a blood pH of 7.35 to 7.43. Go outside that and you're heading for multi-organ failure.
And the two big factors controlling this are PASO2, the respiratory component, and bicarbonate, the metabolic buffer.
And you'll notice for the respiratory gases, PASO2 and PAO2, we stick to the non-SI unit, MHG, as the convention for partial pressure. It's just historical practice in respiratory medicine.
So the key with ABGs is just recognizing those physiological limits. If the PASO2 is high, that's respiratory acidosis. If the bicarb is low, that's metabolic acidosis.
And that's your takeaway, key takeaway 3. You have to define the clinical context, time of day, position, menstrual cycle before interpreting a hormone. Forgetting that makes the number useless. And ABGs provide those critical, narrow ranges that define the boundary between stability and emergency.
Let's check in on that posture dependence we talked about.
Good idea.
Check-in question. A patient who is sitting in the waiting room for an hour has a blood draw showing aldosterone at 550 pml. Could this be a normal result? And if so, why?
Yes, it absolutely could be normal. Aldosterone levels go up when a patient is erect or sitting. If they'd been lying down, that result would be high, but sitting allows for that physiological increase. The answer is the patient's posture.
Right. Okay, let's move beyond blood to the body's other compartments. Urine, spinal fluid, the gut. These have totally different rules.
They do. When you're interpreting urine analytes, the first critical detail is the sample type. Most of the ranges in the source apply to 24-hour collections.
Which means the patient has to collect all urine produced over a full day. That's notoriously hard to get right.
Very difficult. And unlike serum electrolytes, the urinary output of sodium and potassium is highly dependent on diet.
The quoted values are for a typical Western diet.
Exactly. If your patient is on a very low-salt diet, their 24-hour sodium excretion will be extremely low, and that's totally normal for them.
We also look for endocrine markers in urine. 24-hour urinary cortisol gives you an integrated measurement over time, which is often better than a single blood sample for screening Cushing's.
We also look at catecholamine metabolites, like metadrenalins, when we're thinking about a pheochromocytoma.
And what about creatinine in the urine?
The 24-hour excretion ranges again reflect muscle mass differences between sexes, but checking that the patient is excreting a normal amount of creatinine for them also helps you validate that the 24-hour collection was actually complete.
Got it. Now, cerebrospinal fluid, CSF.
This is the protected sanctuary. It's isolated by the blood-brain barrier, a critical filter that keeps the CNS environment incredibly stable.
And that translates to extremely low normal values. CSF cell counts are tiny, less than 5 cells per microliter, and they must all be mononuclear.
Right. The presence of even a single neutrophil, a polymorph, in someone with a fever or headache is an immediate red flag for bacterial infection.
Total protein is also way lower than in serum, just 0.14 to 0.45 GL.
And that low protein is why it's so hard for some IV antibiotics to get into the brain. The barrier keeps them out.
But the most critical rule for CSF is the 2/3 rule for glucose.
Yes. The absolute CSF glucose range is 2.3 to 4.5 millimol. But that number is secondary to the ratio. You have to interpret it relative to the blood glucose level at the same time. CSF glucose should be about 2/3 of the plasma level.
Why is that ratio so important?
Because if a patient's plasma glucose is, say, 12, so they're diabetic and uncontrolled, a CSF glucose of 4.0 might look normal if you just look at the absolute range.
But 4.0 is only 1/3 of 12.
Exactly. It suggests something in the CSF space is gobbling up glucose, and that's the classic sign of bacterial meningitis. The bacteria are just rapidly metabolizing it.
Wow. Okay, and our last specialty sample, feces. This gives us a window into the gut and pancreas.
Two main markers here. First is calprotectin, the primary inflammation marker. A normal level is less than 50 Schemmers. If it's high, it suggests ongoing inflammation, typically from inflammatory bowel disease.
And then there's elastase for pancreatic function.
Fecal elastase is an enzyme released by the pancreas. A level over 200 enzyme means the pancreas is working fine pancreatic sufficiency. Below 200 is a strong indicator of exocrine pancreatic insufficiency, meaning the patient probably needs enzyme replacement therapy.
Okay, let's get the takeaway for this section.
Key takeaway 4. For CSF, remember the less than 5 cells rule and the 2/3 glucose rule. They are non-negotiable for diagnosing infection. For urine, remember that electrolyte ranges are diet-dependent and you need to validate those 24-hour collections.
Let's use that 2/3 rule for a final check-in.
Lights.
Check-in question. A patient is hyperglycemic with a plasma glucose of 10.0 millimoles. If their CSF glucose comes back at 5.5 millimole, is the ratio concerning for bacterial meningitis? Or is it likely normal for this patient?
Good one. So 2/3 of 10.0 is about 6.7. A level of 5.5 is a bit below that expected ratio, but it's still within the absolute normal range. So it's definitely concerning. The ratio is dropping, suggesting consumption, so you'd want to correlate that clinically and follow it closely.
All right. Section 5. The hematology suite. This is quality control on the body's factory floor. How well are we making and maintaining our cells and clotting proteins?
And these values require constant attention to the patient's sex because the ranges are fundamentally different. For red cells, you have to start by considering sex because of androgen effects and physiological blood
Right.
loss.
Hemoglobin is significantly higher in adult males than females.
Same with packed cell volume, or hematocrit. It's zero point 0.40 to zero point 0.54 for males, but only 0.37 to 0.47 for females. A woman with a PCV of 0.38 is normal. A man with the same result would be anemic.
But the indices, the characteristics of the individual red cells, they're generally universal in healthy adults.
Right. Mean cell volume, MCV, defines the size, which is crucial for classifying anemia.
Yeah.
And mean cell hemoglobin, MCH, measures the weight of hemoglobin in each cell.
We also look at reticulocytes as a measure of the bone marrow's output, how well the factory is replacing old cells.
Yeah, a high reticulocyte count suggests the marrow is trying to compensate for rapid loss, like from a hemorrhage.
Okay, what about white cells?
Total white cell count is 4.0 to 11.0 by 109L. But the differential count, the breakdown, is the critical diagnostic tool.
And we need to know the hierarchy. Neutrophils are always the highest number, followed by lymphocytes.
Right. A high neutrophil count is the classic sign of a bacterial infection. High lymphocytes often suggest a viral illness. Then you have monocytes, eosinophils for allergy or parasites, and finally, the rarest, basophils. Recognizing that normal hierarchy lets you spot abnormalities immediately.
And another inflammation marker, ESR, also shows sex dependence, is higher in women.
It is, and the source also notes that higher ESR values in older patients aren't necessarily abnormal. It's a common physiological effect of aging. That background level of nonspecific inflammation just rises over time.
Okay, last group here, coagulation and storage.
The COAG screen assesses clotting time. Prothrombin time, PT, measures the extrinsic pathway used for monitoring warfarin. APT measures the intrinsic pathway for monitoring heparin.
And D-dimers, they're critical but have to be used carefully. A low D-dimer is great for excluding a clot if your clinical suspicion is also low.
But a high D-dimer is nonspecific. It goes up with infection, inflammation, pregnancy, trauma. It only confirms that clot breakdown is happening somewhere in the body.
And finally, the storage markers,
Yeah.
particularly ferritin, our iron stores.
Which again shows dramatic sex and hormonal dependence. Premenopausal women have a lower reference range, 15 to 200 ornial, to account for menstrual blood loss.
Whereas men and postmenopausal women share the higher range of 20 to 300.
And this is such a high-yield clinical concept. A ferritin of 20 in an elderly man is profoundly low. It suggests serious iron deficiency anemia from chronic bleeding. But a ferritin of 20 in a young woman with heavy periods might be considered normal for her, even if it's approaching insufficiency.
And vitamin B12, normal is defined as greater than 210 NGL.
Right. So, key takeaway 5. Hematology requires constant consideration of sex norms for things like HB, PCV, and ESR because the numbers are just different. And that dramatic shift in the ferritin range after menopause has to be factored into any workup for anemia or iron overload.
Okay, we spent all this time establishing the adult normal, but maybe the biggest mistake a young doctor can make is applying that adult range to a patient who is actively growing or in a different physiological state. This is the section we're calling the moving goalpost.
A very good name for it. For children, a result that is completely normal for an adult could indicate severe, even life-threatening pathology. And this is largely because children have vastly different body compositions.
And creatinine is the textbook example here. An adult male creatinine is normal, up to 111 modal, based on their large muscle mass. But a child, say 4 to 12 years old, has a normal range of only 20 to 57.
The difference is massive. A creatinine of 70, totally normal for an adult, might suggest significant renal impairment in an 8-year-old because their baseline creatinine production is so much lower. You have to consult pediatric-specific charts.
The analogy of a small engine versus a truck engine is perfect.
It is. And hormonal changes are equally vast, categorized by the Tanner stages of puberty. Look at testosterone. Prepubertal males have levels under 0.5 phenol. By stage 5, that explodes to 10 to 30, a 20-fold change that is completely physiological.
We also see a huge shift in alkaline phosphatase, ALP.
A huge shift. During rapid growth spurts, the range is 100 to 400 UL, dramatically higher than the adult range because ALP is released from osteoblasts during intense bone growth.
And then there's pregnancy, which requires trimester-specific interpretation. The body undergoes massive adjustments that make standard adult ranges meaningless.
The first big change is fluid dilution. A pregnant woman's plasma volume expands way more than her red cell mass. This leads to a measurable drop in concentration, what we call the physiological anemia of pregnancy.
So the packed cell volume, the PCV, actually drops across the trimesters.
It does. A PCV of 0.29 would be anemia in a non-pregnant woman, but in a third trimester patient, that can be a totally normal state.
And the hormonal surges are just incredible.
Unbelievable. Progesterone, essential for the pregnancy, increases from a max of about 150 unmol in the first trimester to over 1,000 in the third, mostly from the placenta.
And ALP, again, is a great marker of this. It surges in the third trimester, far exceeding the adult range because the placenta is a major source of ALP.
Even the thyroid axis shifts slightly. You need trimester-specific tables for TSH and free T4 because the physiological demands of the fetus narrow and shift the normal bounds.
So let's get the final key takeaway.
Key takeaway 6. Never, ever use an adult reference range for a pediatric or pregnant patient. The ranges for creatinine, ALP, and major hormones are completely different due to growth development or massive physiological adjustment.
All right, one last check-in on this most dynamic section.
Alrighty.
Check-in question. A non-pregnant 30-year-old woman has an alkaline phosphatase and ALP of 150 UL. Is this normal? And then, if that same woman was in her third trimester, would 150 UL be normal?
Okay. If she's not pregnant, 150 is mildly elevated above the adult range and would need investigation. However, if she's in her third trimester, the range extends up to 229 UL, which means 150 is perfectly normal and physiological because of the placenta. The context of pregnancy completely shifts that boundary.
Perfect. So we've completed our structured journey through laboratory reference ranges. We've covered the language of SI units, the essential details of venous chemistry, the need for context in hormones, the special rules for the protected sanctuary, the CSF, the influence of sex and age in hematology, and the huge shifts for pediatrics and pregnancy.
And remember, the difference between just memorizing a number and real clinical intelligence is understanding the why behind it. Knowing that creatinine changes with muscle mass, that aldosterone changes with posture, that the CK normal range expands for specific ethnicities. These insights transform you from a reader of tables into an informed clinician.
These ranges are the baseline. You have to know what health looks like to accurately identify pathology.
Exactly.
And as we noted when we were talking about vitamin D, even normal can be influenced by geography and environment. The reference range for vitamin D is often established by averaging population data gathered across an entire year.
Which raises an important and I think final provocative thought for you to carry forward. If a laboratory in a northern latitude sets its reference range for vitamin D by averaging the high levels from summer and the low levels from winter, is that resulting normal range truly reflective of optimal physiological health?
Or is it just an average of deficiency and sufficiency?
Precisely. It highlights how population-based statistics can sometimes mask a deeper underlying physiological need, and it really challenges the very definition of what we call normal.
Is normal always optimal? It's a question that really defines the practice of medicine. Keep that critical lens sharp as you continue to build your knowledge. That's all for this deep dive. We hope this is giving you a memorable, structured map for navigating the complex world of laboratory reference ranges.